Hi, welcome to my presentation on the National Diagnostic Reference Level Services Nuclear Medicine Survey for 2021-22. My name is Toby Beveridge and I work in the medical imaging section at Arpansa. I'll start with a brief history of DRLs in nuclear medicine in Australia. Back in 1998, Richard Smart and Jocelyn Towson conducted a survey on behalf of the ANZ, S&M and ARPS of the 172 Australian and New Zealand nuclear medicine providers that they were aware of at the time. The survey included a list of around 80 possible procedures, and participants were asked to provide the doses they delivered to average-sized patients for any of the procedures that they offered at their facility and any additional ones that were not covered in that initial list. They had just under 100 responses to the survey, and a table of the most common activities and reference activities was created that included all procedures reportedly offered by 10 or more participants. They defined the reference activity as the 75th percentile of the distribution of administered doses, and that makes it analogous to diagnostic reference levels as used in CT and other modalities. The survey was repeated in 2008 and the tables were updated. Both the 1998 and 2008 surveys requested information about the doses delivered to pediatric patients, so there are additional tables with the maximum minimum doses provided for pediatric protocols, but neither survey included any questions regarding the doses delivered as part of the CT portion of a hybrid imaging study. Arpansa started our National Diagnostic Reference Level Service back in around 2011 and became involved with the nuclear medicine side of DRLs in 2014. Our first survey was very different to the one conducted by the ANZ and S&M, in that rather than asking for the activity prescribed for a given protocol, we asked for the actual doses delivered to individual patients that attended a participant's facility over a 4-week period. I should mention here that Arpansa didn't unilaterally decide how the survey would be conducted. Whenever we conduct a DRL survey, our first step is to form a liaison panel of interested parties who then guide the design of the DRL program. For this first nuclear medicine survey, that panel included representation from the ANZ, S&M, AANMS and ACPSEM, as does our panel this time, although we've also added some Department of Health representatives as well. Anyway, there were several reasons why we chose to conduct the survey the way we did. One was to allow the capture of CT dose information, another was to make the administered activity DRLs based on actual administered activities rather than prescribed doses, and another was to allow the results of the survey to be used when completing a UN Scientific Committee on the Effects of Atomic Radiation survey of global medical radiation per capita dose. And it was that UNSCIA survey that informed how scans were categorized in both the 2014-15 and the most recent DRL survey. And that's also why therapeutic doses were included in that first survey. Due to the nature of the survey, we were able to create tables for DRLs for the general nuclear medicine PET and the CT portion of hybrid imaging studies. In cases where there was an existing reference activity in the ANZ S&M tables but insufficient data in our data set to create a DRL, the ANZ S&M data was used. And then finally here, crucially, the nuclear medicine DRLs we published became recognised by the Diagnostic Imaging Accreditation Scheme in July 2017, meaning that it has become a requirement of DIAS that nuclear medicine facilities conduct regular DRL comparisons. That brings me to the 2021-22 DRL update. As I mentioned, the current DRLs have been recognised by DIAS for almost 5 years now, and the data that they're based on in some cases is 7 or 8 years old, but in many cases it's 14 or 15 years old, being based on the 2008 ANZ S&M survey. So during that time there have been considerable changes to nuclear medicine utilisation and technology, particularly in terms of PET. So we decided it was time for new DRLs. This time around, the liaison panel has decided to go for something halfway between the 2008 ANZ S&M survey and our previous 2014-15 survey, whereby we asked for both the prescribed activity and the doses actually delivered to patients. This time, rather than going for a 4-week collection period, we've gone for a 2-week period. And we also tried to learn from a few of the mistakes we made last time round. So this time we predefined all CT regions And we also made sure to request CTDI for CT scans. The survey itself is Excel-based. There are separate workbooks for nuclear medicine and PET, and each workbook contains 3 worksheets. One which requests information about the facility and the equipment that they have. One that asked for a list of prescribed doses, and within that, if there's a weight correction applied, how that correction is applied. And then there's a final worksheet that includes a space to enter all your administered doses. The goals of the design of the spreadsheet were to allow flexibility, so to allow for different study types and pharmaceuticals and isotopes to be entered, but at the same time to minimize typos and intra-survey variations, which you do. We certainly found a lot of in the previous survey. So our solution to that was to use a base set of protocols, much like the ANZ S&M originally did back in 1998, but also add the ability to add additional protocols to the protocol page, but only allow predefined protocols on the administered dose page. So if a mistake is made, it's made on the protocol page and carried throughout the remainder of the spreadsheet, rather than having variation between individual patients on that patient spreadsheet. Invitations were sent to all facilities that had notified the LSPN register that they operate a gamma camera or PET camera. So in theory, that should be every nuclear medicine provider eligible for a Medicare rebate within Australia. The invitations were sent via Services Australia, which is the body that oversees the LSPN register, but because of their privacy legislation, they're not actually able to tell us who they send invitations to. So the first step in the survey process is for invitees to contact Arpansa to register their intent to conduct the survey. And we had 126 facilities register with us. 108 of those requested NucMed spreadsheets and 59 requested PET spreadsheets. The survey wrapped up in March of this year, at the end of March. So we were able to compare now the community response we got this time compared to back in 2015. And overall, we had more facilities, and particularly we had a huge increase in the number of PET facilities that participated. In terms of patient administrations, we got about half the number of nuclear medicine administrations and SPECT CT scans that we got last time around. That's due to shortening the collection period from 4 weeks down to 2. But this was offset in the case of PET because we had almost double or over double the number of facilities. We actually had about the same number of administrations and CT scans this time around as we did last. And it's worth noting too that the quality of the information we got this time around, particularly in terms of CT, was much higher than it was last time around. And that's because we had predefined CT scan regions, and also because we've asked for CTDI vol this time around. Of the 108 facilities that registered to participate in the NucMed survey, 90 have returned surveys to me so far, and 85 of them have been included in the dataset. I need to ask a few more questions about the other 5. This table shows the top 10 procedures ranked by the number of facilities that reported conducting at least one of these scans during the 2-week period. I've also included the number of facilities that theoretically offer each procedure and the number of studies that were conducted during the survey period. Not surprisingly, bone scans comes out on top, and all in all, there's not too many surprises regarding the most common scans. This table compares the administered and prescribed dose delivered during those top 10 procedures. It compares them at the median dose distribution and also the 75th percentile of the dose distribution. And also for comparison, there's the DRL, the current DRL, where one's available. Ideally, the administered and prescribed doses would match, and all in all, they do quite well. Similarly, ideally, the DRL would either be at or a bit above the 75th percentile of the prescribed doses, and that also appears to be the case. This table summarizes the data submitted as the CT portion of SPECT CT scans. Once again, it's ordered in terms of the number of facilities that reportedly conducted one of these scans during the collection period. And in terms of that, extremities were performed at the most facilities. In terms of the actual number of scans performed, CT scans of the heart as part of MPI scans were by far the most common, and pleasingly they're also the lowest dose, both in terms of DLP and CTDI vol, which is a good indication of how well optimized the specialist cardiovascular units can be. Moving on to PET, here are the top 6 procedures reported. The number one was, not surprisingly, whole body FDG scans. Every participating facility both offered and recorded one of these scans, and then falls away a bit as you go through some of the other procedures. All in all, there are 5 protocols reported 100 times or more during the survey period. In terms of the doses delivered during these procedures, every single facility reportedly used some kind of dose correction, be it based on patient weight or BMI. So for the prescribed activity shown here, I first calculated what would have been delivered to a 75 kilo patient or a patient that had a BMI of 26. So that's what I'm comparing the administered doses to. And that may explain some variation between the administered and prescribed doses that you see here. Although all in all, they do still match fairly well. And finally, we can look at the CT component of PET CT scans that were reported. Most studies were of the vertex brain down the proximal mid-thigh region, and there wasn't a huge variation between the different scan regions in terms of CTDI vol, with the exception of brains, but that's probably because it's reporting against a 16 centimeter CTDI phantom rather than the full 32 centimeters phantom. That concludes my summary of the submitted data. In terms of next steps, there's a fair bit more data analysis to do, but after that's done, a report will be presented to the liaison panel. We'll then need to make a few decisions. One topic of discussion will be whether or not additional procedures should be incorporated in the DRL tables, and similarly, if some of the existing DRLs should be removed from the table. Also, there'll be a discussion about whether or not and how to incorporate weight and BMI corrections into DRLs. In some cases, like for FDG scans, it's obvious that everyone's doing weight corrections, and it would only make sense to issue a DRL that is also weight-based. However, there are some protocols, I'm thinking particularly of MPI scans, where a small but significant portion of the nuclear medicine community seems to do some kind of correction, be it based on weight, BMI, or even body circumference. And whether or not that's incorporated into the MPI DRLs will need to be discussed. And finally, although we had a lot of CT data submitted, when that data is broken down per facility, per region, the data starts to look a bit sparse. And so it may not lead itself to being analysed the same way that we analyse the MDCT data, where we take the median dose delivered at each facility and take the 75th percentile of the distribution of medians to calculate the DRL. When you have a small number of scans conducted at each facility, that may not be an appropriate technique, so that's something else for the panel to discuss. That's the end of my talk. Thank you very much for your attention. If you'd like to ask me any questions, please email at toby.beveridge@arpansa.gov.au. Thanks again.